Hello friends, now I will be talking to you about MDS, that is myelodysplastic syndrome. This is a disease which affects the elderly person. At the age of 50 to 80 years, and it's an acquired clonal abnormality. And what's the basic problem? There is a maturation defect. As the maturation is defective, that lead to ineffective hematopoiesis, and that lead to pancytopenia in the peripheral circulation, but the MCV is high. This is a very important point to note it. Another important point is bone marrow is hypercellular, although in the peripheral smear we are getting pancytopenia. So this one condition, hypercellular bone marrow with pancytopenia in the peripheral circulation, and it can develop AML in 30% cases. That's why we can also say it very comfortably that this is a pre-leukemic condition. It's a pre-leukemic condition. Okay, as there is pancytopenia in the peripheral circulation, so due to anemia, patient usually has fatigue, and due to low TLC count, patient is prone to infection. So this is due to low HB, and this is due to low TLC count. And of course, as the platelet count is reduced, patient has bleeding tendency, and spleen may be palpable in around 20% of the cases. Well, as I told you, in 30% cases, patient can go into acute myeloid leukemia. But as the disease involves the elderly person, most of the patient, they die of infection and bleeding. Infection and bleeding because of bone marrow is also already worn out. So infection and bleeding are the common cause of death in these patients, but in some other cases AML can occur. Now, what is the origin of this disease? Origin of disease. It may be primary idiopathic, but sometimes it may be therapy related. Many of the chemotherapy can induce this problem. Okay. Now, what are the cytogenetic abnormalities? Most common is deletion of 5q. That is 5q negative is the most common cytogenetic abnormality. Monosomy 7 is seen in little younger patient, and the most common trisomy is trisomy 8. Now, so we have 5q minus 7 and 8. Now, how we investigate this patient? What you get in CBC? In complete blood count, you get pancytopenia, I discussed, and dimorphic anemia. A very important feature, increase MCV. And the neutrophils have bilobed nucleus, and this is known as Pelger-Huet abnormality. Okay. Now, what we get in bone marrow? you get ringed sideroblast. You get micromegakaryocyte, also known as pawn ball megakaryocyte, and of course blast cells are seen, which can be maybe 1 to 20% or sometime even maybe more than 20% also. More the number of blast cells in the bone marrow, more likely that patient may go into acute myeloid leukemia. And genetic study for 5q minus, this is a mandatory when you are investigating a case of myelodysplastic syndrome, because this is the most common cytogenetic abnormality. Now let us see what is the classification. WHO classification is like this: disease, bone marrow finding. We call disease as a refractory anemia. Refractory anemia, when the blast cells are less than 5% in the bone marrow and there is only erythroid dysplasia only. That means lineage involved is only RBC. Second is refractory anemia with sideroblasts. Here again blast cells are less than 5%. Here also less than 5. But we are getting ringed sideroblasts where they are more than 15% in the bone marrow. That's why we say RA with sideroblasts. Then third is refractory cytopenia with multi-lineage dysplasia. Well, as this word itself, refractory cytopenia, there is pancytopenia will be there. That means multi-lineage, that means maybe RBC, WBC, platelet 2 or 3 lineage are involved. So blast cells again less than 5%, but 2 to 3 lineage dysplasia is there. Then refractory anemia with excess of the blast. Excess blasts, here the blasts are 2 to 20%, usually more than 5%. And of course there is 2 to 3 lineage dysplasia is also there, additional features there. So difference between this and this is that blast cells are less than 5%, but here blast cells are usually more than 5%, it may be as high as 20%. And the fifth one is myelodysplasia with 5q minus, blast cell again less than 5, but here the platelet count may be increased. Count may be increased. And the sixth one, MDS unclassified. If none of the above fits, we call as unclassified. Now let's see what is the international prognosis score. The prognostic variable and score. Score is 0, 0.5, 1, 1.5 or 2. If blast cells percentage less than 5, 0 score, 5 to 10, 0.5, 11 to 20, 1.5, more than 20 is 2. Okay. Then karyotype. Point to note it, there is nothing like 1. 5, 5, 10, 11, 20, and this is the blank. Karyotype, good, 0 score, intermediate, 0.5, poor is 1. Cytopenia, okay. Cytopenia, lineage involved, 0 to 1 is 0 score, 2 to 3 is 0.5. Point to be noted, in this lineage involved are 2 to 3, 2 to 3. So we get score of 0.5 if 2 or 3 lineages are involved. So now what is the risk group score? If score we call as low risk, 0 score. Intermediate 1, this is IM stand for intermediate, here also intermediate. Intermediate 1, the score is 0.5 to 1. Intermediate 2, 1.5 to 2. High, more than 2.5. How to remember? Intermediate 1 is 1, intermediate 2 is 2. Okay, this is the international scoring for the risk factor. Now, how to treat a case of myelodysplastic? Repeated blood transfusion is the answer. Repeated. Why repeated? Because patient has pancytopenia, infections, patient are very anemic, so we can give erythropoietin. You have to give infection by giving antibiotics. Then we can use certain disease specific drugs. The disease specific drugs are thalidomide or lenalidomide. But if deletion of 5q is there, then we can use azacitidine or decitabine, but this we use in 5q. And of course, in the younger patient, we can go for bone marrow transplantation. This is all about myelodysplastic syndrome. Thank you very much.